They don't spread through the air. You can't catch them by touching or kissing or sharing needles. Shutting down borders and closing down businesses will not reduce the number of deaths that they cause. There is no national emergency declared to fight them, no global collection of funds to combat them, no national education campaign to defeat them. No, we have not taken them that seriously. Yet, 7 out of every 10 deaths on the planet are caused by them. What are these criminally underrated killers of which I speak? Non-communicable diseases. They call it the silent epidemic, and it lays waste to swathes of humanity through heart attacks, strokes, hypertension, diabetes, cancer, and respiratory diseases, among others. In Ghana, more than 40% of all funerals are caused by NCDs. It is scandalous that we have not, as a nation, made this our #1 health priority. But that ends tonight with the first ever Joy News National Dialogue on Non-Communicable Diseases. Hello, good evening, and welcome to the Joy News National Dialogue on NCDs, the silent epidemic. We're coming to you live from the Joy News studios here in Kokomlemle, and you can catch us this night live on our broadcast on the Joy News channel, Joy 99.7 FM, myjoyonline.com, and across all of our social media networks, Facebook, YouTube, and X. My name is Kojo Yankson. Now, tonight, we face the silent epidemic of non-communicable diseases head-on with a thought-provoking, agenda-setting discussion featuring some of the most important voices in this space. We'll talk about how to increase awareness and knowledge of NCDs, how to fund their treatment, and perhaps most importantly, how to prevent them from even happening in the first place through the use of proactive health policies at the national level. This national dialogue is held under the auspices of Farm Access and NORAD. Now, let's meet the guests who will be participating in this conversation. It is my pleasure to introduce Dr. Jacqueline Thompson. She is a family physician for the Greater Accra Regional Hospital. Dr. Kwesi Boahene is Director of Health Systems at Farm Access. Professor Gordon Abekan Nkrumah is Deputy Health Services Management, in charge of, is at the Department, of Health Service Management at the University of Ghana Business School. Dr. Eric Nsia Boating is Head of Monitoring and Evaluation at the Ministry of Health. And Labram Musa is National Coordinator for the Ghana NCD Alliance. Ladies and gentlemen, it's a pleasure to have you here at Joy News. Thank you very much for making the time.
Thank you. Thank you.
Now, there's a lot for us to get through, lots to talk about. But to set the tone, help us understand why we're here, let's listen for just a moment to Dr. Kwesi Boahene. He's the Director of Health Systems at Farm Access.
I really appreciate the efforts and the collaboration between Farm Access and Joy News Television for this program. And also sincere appreciation to our partners in Ghana. You know, we work with the Ministry of Health, Ghana Health Service, National Health Insurance Authority, HEFRA, Christian Health Association of Ghana, CHAG. We work with healthcare providers, Greater Accra Regional Hospital, academia, research institutions, University of Ghana is an important partner, and of course the Ghana National NCD Alliance, for their work. And you projected an image that is correct, because NCD is a silent killer. But at the same time, also give credit and space to our partners for the work that they do. And I do also appreciate the collaboration that you have with us to make sure that healthcare is affordable and quality is optimal for every Ghanaian. So the PharmAccess, the organization that I represent, committed to contributing to making sure that healthcare is affordable, like I said, it's accessible, the quality is in order. And we work in 20 countries across Africa, including Ghana. So Ghana, we have an excellent team headed by Dr. Masua Antwi, who could not be here for other responsibilities. As an organization, we leverage innovations and data, and I think that's important in this conversation. And so from supporting organizations that I mentioned, to really work on mobile health solutions, digital platforms.
I need to understand that a bit of a problem with your microphone. We are going to resolve that so that we can hear you a bit clearer. But listen, while we're getting that done, perhaps it would be a good time to take 5 minutes to introduce ourselves to the concept of non-communicable diseases. Watch this.
Non-communicable diseases, or NCDs, are a growing threat to global health, and the cost burden is staggering.
If you ask me as a clinician, one condition I fear most, in fact, I fear diabetes even more than cancer, because once your sugar is so high, it affects virtually all tissues, all organ systems in the body.
The World Health Organization reports that NCDs account for over 30% of deaths in Ghana, with diabetes prevalence doubling in the past decade and affecting around 6% of the population. Also, hypertension, often undetected until complications arise, silently impacts over 1/3 of Ghanaian adults.
About 612,000 new cases of hypertension alone are diagnosed every year. That is quite consequential in terms of the financial implications.
It's like a ticking time bomb, and if we don't address it, it's going to be catastrophic.
In this documentary, we uncover the human stories behind these statistics and explore impacts of NCDs on the affected persons, the family, the health system, and the national purse.
Yeah, so it's about time we took this conversation forward. Here in Ghana, 40% of all deaths are caused by non-communicable diseases. Let's get to grips with it. Now, just before you watched that, we were listening to Dr. Kwesi Boahene. He's Director of Health Systems at PharmAccess. Bit of a technical issue there. So we're going to have him very patiently just restart that delivery for us.
No, so thank you very much for hosting this event, which I think is of critical importance to the country. And certainly huge appreciation to our partners, Ministry of Health, Ghana Health Service, National Health Insurance Authority, HEFRA, Christian Health Association of Ghana, Greater Accra Regional Hospital is here. We work with academia, Professor Nkrumah represents University of Ghana. We also have patient advocates, Ghana National NCD Alliance is an important player in these efforts. So huge appreciation on my part for the work that you've done and keep doing, and also huge appreciation that we've been able to partner with them to get these efforts going. So as an organization, PharmAccess, which I represent, our mandate and of course objective is to ensure that everyone in Africa will have access to healthcare. And we do that by partnering with key institutions across Africa. So Ghana, we work with the partners I mentioned. We have a fantastic team in Ghana, headed by Dr. Masua Antwi. And our focus is how do we use innovations and data to drive change in healthcare? You know, I always tell people that 25 years ago, nobody imagined that mobile technology will be able to transform Africa the way that we've done. You know, 57% of Africans do not have bank accounts, but they can do business due to mobile payments, or we call them mobile money in Ghana. So our conviction is that if mobile technology has done this for financial inclusion, can we also use mobile technology to transform health and tackle NCDs? The answer is yes. So we committed towards that. Now we are here talking about NCDs. Why is that important? You know, Ghana, as one of the members of United Nations, has signed the UN Declaration on Universal Health Coverage, meaning that 2030, which is 6 years from now, every Ghanaian will have access to basic healthcare without any financial burden. That is the aspiration of the country. And they are working hard on it. And I can confidently say that if I compare Ghana with other African countries, Ghana has made good progress over the years, but there are challenges. One of them, and if we want to achieve USC, is to tackle NCDs. You know, what you said is perfectly right. If I walk on the streets of Accra and I meet 100 people, 43 of them will die of diseases associated with NCDs. And most of them don't know. So you cannot blame the healthcare, the policymakers. You cannot blame the healthcare providers, but we all have to come together to make this work. You know, the picture is glooming when you listen to the World Bank. That says that if we don't take immediate action now, by 2030, Ghana will spend $6 billion every year on tackling NCDs. That is a cost that as a country, which is aspiring to be a middle-income country, we cannot afford to ignore. So we all have to be part of it. And having us here to have that conversation, and I'm really inspired that if you want to address this in a comprehensive manner, we need to engage experts from across the board. That's why we are here with academia, with healthcare providers, with policymakers and patient advocates to really drive home and mobilize efforts to achieve or defeat NCDs. So that is important for us as an organization, it's important for the country. And we've seen how, because some people cannot pay for care, they are pushed into poverty. That has to stop. You know, so, and in conclusion, what I would also like to emphasize that I'm glad, you know, also based on your introduction, that this dialogue is actionable, will focus on actionable solutions. That is what we need. You know, awareness raising, early detection, prevention, treatment, and above all, building support systems to help people. You know, this, we call it dialogue, but it's more than a conversation. It's a call to action that we all have to embrace. And we are proud to be doing this with our key partners in the country. Yeah.
Well, I want to thank you for that. Dr. Kwesi Bohene is the Director of Health Systems at Farm Access. We're hoping he stays with us a little bit so that he can also be a key contributor to our ongoing dialogue. Now, this conversation is indeed a dialogue. That means it's not just about us here in the studio, it's even more about you watching, listening, wherever you may be. So be a part of the conversation. On X, you can post and use the hashtag #JoyNationalDialogue. At some point, if we get the opportunity, we would love to hear you when we open the phone lines with your contributions, questions, and views. Because by the end of this conversation, we have to have a vision and a plan of how we will stem the tide of death caused by non-communicable diseases. So let's not waste time, let's get into it. Here in the studio, we have Dr. Jacqueline Thompson, family physician, for the Greater Accra Regional Hospital. Professor Gordon Abeka Nkrumah is with the Department of Health Services Management at the University of Ghana Business School, very important. Dr. Eric Nsia Boateng is the head of monitoring and evaluation at the Ministry of Health, and Labram Musa, national coordinator of the Ghana NCD Alliance. Dr. Thompson, if you don't mind, I'd like to start with you because you're sort of at the business end of this. You meet the Ghanaians who are coming to you with these non-communicable diseases. And I start with you because there's something I've been curious about. These numbers are staggering, 40% of all deaths. It's scary to hear it. But I wonder how we got here. Was it sudden? Is it a sudden new surge? Or did it build gradually? In your experience, how did we get here?
So, thank you very much. It's been something that has gradually grown over the years. Okay, so with the introduction of things like us adopting a Western diet, physical inactivity, stress-related issues and all that, it's something that has grown over time, and then that's how come we've gotten to this point. And as time has gone on, much attention has not been given to it. So if the problem had been seen in the beginning, it would have been nipped in the bud earlier on. But it's, like we are saying, has been a neglected area. So that's why we are facing this problem currently.
Now, I suppose the scariest part of it is that by all estimations, half of those who have NCDs have no idea. I mean, Dr. Nsia Boateng, you head monitoring and evaluation at the Ministry of Health. No doubt if there are any numbers, you have them. Talk to us. I mean, first of all, if indeed half of those who are suffering and likely to die from NCDs are not aware that they have it, what in God's name can be an intervention against something that you don't even know is killing you?
Yeah, thank you very much, Kojo. I think as a health sector, what we have tried to do is to make sure that we improve the policy environment. And in so doing, you need to come out with legislative documents like the National NCD Policy, the revised version, which is 2022, and then the Tobacco Control Regulation of 2016-2017, and then the National Policy on the Alcohol, which is also 2016. In fact, over the years, we always talk about education. But like you rightly said, I mean, if about half of those dying are not aware that they have symptoms of NCDs, then what it means is that we need to also do more to address that. So we do admit that when it comes to education, we need to do more. And in doing more, what we mean by that is that we need to make sure that people who have the symptoms do report early to the health facilities. That is where we can screen them, detect, diagnose, and provide the needed care. And then we have other groups that are also not even aware that they have the symptoms, that they walk around. And for those groups, what we need to do is to also improve screening at the community level. So what this means is that when you look at the healthcare system, the lower level of care, the community level, the chips that we have in our system is where we need to strengthen to provide a capacity. The capacity will be in terms of equipment, in terms of the human resource distribution, in terms of other resources like, for example, TB apparatus and the rest. These are the things that we need to do. But I think if you look at the policy, what we have stressed on or focused on is the preventive aspect of it. How do we make sure people who are exposed to the risk factors know that these are the issues that they are likely to face, and these are the implications? It affects individuals, it affects society, and it even affects the nation, the economic cost, as we all know. So we are focusing on more of education, collaborating with the Ghana Education Service and other stakeholders to make sure that we have targeted interventions. And here we are looking at all groups within the socioeconomic bracket. How do we do that? We need to also leverage all media, print, social, and electronic. So these are some of the proposals that we have put in the document that, together with the stakeholders, we'll be able to do. There's another important committee that we've set up, a multi-sectorial NCD steering committee, with key members from all the stakeholders we can talk of, Ministry of Finance, the Security, Education, and the rest. So these are some of the proposals we believe that we can do, and then let people who are not aware and they are dying silently also get to know this, and then make informed choices about their lifestyle.
We'll take the opportunity to assess some of these policies and see how.
But I think there's an important point here.
Certainly.
So the fact that we know that about 40% of mortalities are from NCD, the numbers are too high, but it's important that we know. Because if we don't know, we can't do anything about it. In addition to that, we know the risk groups or the risk factors. So a lot has gone in terms of knowledge. The prevention, the care, and others, we have to do a lot about it, but you always have to start from somewhere and build upon it. And I think that the Ministry of Health, the Ghana Health Service, academia, really trying to help us understand the dynamics of it, I think is key, and we should not lose sight of that in this dialogue.
Yeah, we can't really make any decisions without data information, so I take that point. Labram, we keep hearing about the need for education, right? I mean, how misinformed is the average Ghanaian about NCDs? In the work you do you find that this is something people just don't know anything about? What would you say should be the focus of any education campaign?
So thank you very much, and let me also commend Farm Access for putting this together, and of course, Joy, and for ensuring that at least at any point in time our health is prioritized. So let me say that indeed I have been a participating stakeholder as far as even the development of the NCD policy is concerned, and so let me say that. In terms of awareness creation, yes, the document, Ghana always have fine policies, but the issue always has to do with, the deliberate effort to roll out public awareness campaign is something which is practically missing. And I'm saying this on the back of the fact that we always wait once, the world is celebrating maybe World No Tobacco Day or World Diabetes Day, then we make all the, and then that is the way we go sleep. And I think that is actually, affecting, the extent to which the prevalence continues to grow, Yes, so people originally really are aware of the, of the situation, especially at the southern part of the country, the Accra, the city. But when you go to the downtrodden communities, like the rural communities, people virtually are not aware of, of these conditions. And that's the reason why we are also experiencing a lot of, these, happenings around the rural communities, and especially we are explaining this because when you would hear of many of them going to the hospital and they are being referred and they are unable to go because of high cost of treatment and all of those things. So the point actually is we need to, come out with deliberate plan. We shouldn't wait, until probably you are waiting. You are celebrating World No Tobacco Day or something. There should be deliberate effort, deliberate plan to continuously, create awareness. And I also say that the media has not also helped, in many regards, especially when it comes to issues around, unhealthy commodities, because the media has been the gateway to propagating, some of these unhealthy stuff. And and once the media channel or something, trust me, then it goes out and then people tend to use them. So yes, for public awareness creation, we are trying our best. I think that we need to do more to ensure that we are able to reduce the burden. Now, when you mention 43% of, diseases, people dying from NCD, I don't want to mention percentage. I would say that let's mention the figure itself. It's about 94,400 people die annually from non-communicable diseases in Ghana. and globally, it's about 40 million people die. In fact, leading cause of preventable death. We say preventable because we can't prevent it. So it is not, about people dying, but these are deaths that can be prevented, and we need concerted effort to be able to, to do this.
Thank you for that. Now, let's talk money. Prof, it costs a lot for a state to manage non-communicable diseases. And I think we have examples. If the NHS shows you their budget for the management of non-communicable diseases, it is scary, it's staggering. And Ghana, at this point where we are now trying to implement the wonderful policies and laws that we've written, obviously the consideration of cost is key. It's probably the reason why we haven't done much so far. Let's try and break down that cost. First of all, let's talk about how much it costs an individual to manage even one non-communicable disease, let alone some of us who have two. Right, and then let's build it up to the national numbers. Let's get an idea of the cost of what we want to do.
All right, thank you very much, and good evening once again. And let me thank Farm Access and your station for lifting this to a higher level so that we can all begin to have conversations about it. And so, yes, we can pick just one. And normally I would want to take hypertension because that's a big issue in Ghana. Of course, diabetes is also a big issue. And oftentimes, these two, they go together. There's been a recent study about Ghana. There are all manner of studies. We know that all of them are not, if you like, what they give is they are basically estimates. But I think the recent study on Ghana puts the costs per month something around a minimum of about $4.3 million to about $5.7 million, averaging around $535 a month per person. And this is actually treatment costs, okay? It is treatment cost. And the irony is that these figures are based on national health insurance prices. And so I would say that this is significantly underestimated because everybody would tell you that if you pick national health insurance prices for services, the way she would tell you that they are way below the market price. And I think that one of the things the current CEO is trying to do is for them to revise the tariffs to ensure that they are consistent with market prices. And I think that I applaud the National Health Insurance for that. So you can see that this figure of 535 per month for treatment is way underestimated. But for me, that is not just the issue because this is just treatment cost. Then we need to talk about opportunity cost. So the person who goes to hospital loses the ability to make income for that particular day. Then you can then talk about the cost of disability in addition to this. And again, think of it also that in Ghana, a huge proportion of what we pay at the hospital is subsidized by the state. And so then you then talk about, for instance, her salary is paid by the state. So this is not part of this money. So you can look at this and see that this is some sort of very, very significant cost per individual per month. And so for me, this is something that's like, he said the World Bank estimating something around, he says 6 billion. Annually. And that's, I'm not too sure whether we would be able to afford that. And even if it were $535, I am asking, what is the average daily wage in Ghana? And if you multiply the average daily wage by, let's say, 28 days, how much do people earn and how much do they commit to treating this? So if you look at it from that way, then you can see that it's a major issue. I know that as we go along the conversations, we may be talking about how do we get the money to finance this. And I think that when we get there, we can have conversations about this. But before I yield, you were talking about issues of how did we get here and education and things like that. And I also think that the problem is because we have just over-medicalized too many things. I don't think that NCD is a medical problem. NCD is a lifestyle problem, okay? And so, for instance, when we're having policy discussion, the policy discussion should be looked at from a holistic perspective. The last time they were talking to me about this, and I was saying that, why are we having this conversation without Ministry of Agriculture? Why are we having this conversation without Ministry of Education? Because if you look at this, it's basically the Ministry of Health only comes in when things are bad. But if we want to prevent this, Ministry of Education has a role to play in terms of education. And then when it comes to, say, lifestyle issues, one of the things I say is that the rich kids in school, they are sitting on a time bomb with their lifestyle. And then the poor kids also have problems because their feeding habits are not good enough. I was the last time talking about the issues of how malnutrition can actually condition your body systems for you to become susceptible to NCDs. And so kids in school at the moment who don't get better nutrition, there is a way that the body can adjust to that situation such that by the time they are 30, they are predisposed. And I say this based on this study which was done after the Second World War in looking at kids that were born during the war and kids that were born after the war. And they were followed for several years. And they realized that kids that were born during the war were more predisposed to NCDs because the body systems had to adjust to deprivation. And so these are issues that we can think about. The good thing is that if you take Ghana, for instance, in schools, we have school feeding program, which is a good intervention. And then we can have educational models that are educating these rich kids so they can go off junk food. So I think that we need to expand the conversation and ensure that everybody is part of this.
Now that you've brought in the issue of nutrition, I want to hear all of us on this one, okay? Because I will confess, every time we talk about NCDs, the only part of the conversation that leaves me a little bit hopeless, as if perhaps the job is bigger than our capability, is the nutrition aspect of it. Doc, you meet real people who come into you with these conditions. If you were to tell the average Ghanaian that he now has to have 2/3 of his portion of food being fruits and vegetables, is it something that we can practicalize in this Ghana, that someone eating fufu is going to have 2/3 of his dish fruits and vegetables? Is it doable? We'll talk about the affordability later, but just on the practical application, do you find when you talk to patients that this is something you can prescribe for them and they can do?
Yes. So yes, when it comes to nutrition, I agree with you that it's something that is quite a dicey area. And looking at how the situation is currently, you mentioned that we should put the financial or the affordability aside. The doability, yes, it is doable. But then we have to make sure that we tell the people why they have to do so, the importance of doing so, the advantages, the benefits, that it plays a role in prevention of all these NCDs. And it's not just about talking to people that I see in my consulting room, but as we've talked about, talking to children in school. So we have to catch them early and then teach them. We need to talk to the teachers as well. So when it comes to this school feeding program and things like that, so that there's equality. So Dr. Gordon talked about the fact that you have to tell the rich kids to stop eating junk food. Then we have to get the poor kids to have more nutritious food to eat. So when it comes to the school feeding program, why don't we make it such that everybody is exposed to the same thing when they come to school, so that they have that? So if we say that this is what we've provided, 2/3 of your meal has to be fruits and vegetables. You don't have any other option. That's what you have to eat. If the unhealthy foods are not available, they'll be forced to eat it. And then it's also got to do with changing of the mindset, changing the culture, knowing that it's not all about eating carbohydrates. You know, for us as Ghanaians, we know that we need to get our energy from the carbohydrates. And it's also because the carbohydrates are cheaper. Okay, so you have your big fufu in a bowl, and then you add some soup to it, and then there's a small piece of meat in there. There's no vegetable. So we have to change the mindset, knowing that deriving energy from carbohydrates is something that will take your energy level only for a short period of time. But when you eat fruits and vegetables, it keeps you fuller for longer because the energy is released over a longer period of time. So when you tell them that do this, you have to back it with evidence to tell them that this is why you need to do it. Because of course, if you tell them that, okay, eat fruits and vegetables. I have people who come to me and tell me either that I don't like vegetables or I don't like fruits. It's because that is not how they have been brought up. My kids eat fruits and vegetables. And some of my friends find it strange. Oh, how come your kids are eating vegetables? And I said, you have to bring them up that way. And you see, us adults as well, we have to get to a point in time where we need to change. So I think that what will drive it is that when you know that this is the benefit, because if you eat something that is unhealthy, you're concentrating more on sugary drinks, you're concentrating more on eating a lot of carbohydrates, eating too much proteins and other things. Once you are able to send the message across that this is what you will gain from doing this, yes, it is doable. Because I have a few people who I've interacted with over the past couple of weeks to months that have changed their diet, and they have come to tell me that, doctor, I have seen a difference. I have seen a difference in my energy levels. I'm able to sleep better, and so many advantages. So once you take them through that process, so then now there was someone who is not even a national of Ghana, and he says that, oh, he didn't realize he was going so bad. He had gone bad, actually. So that meant that, I mean, his health was bad and things like that. So I was also talking to some other doctor colleagues, and they've had similar experiences. So we need to, not just in our consulting rooms, but talk to people in our churches, in our mosques, and other places, talk to our family members that these things are doable, and then we'll talk about the cost.
Indeed, yes, we will come back to the cost. But Labra, I'm still a little skeptical. Look, I'm thinking about my cousin, Kwesi, in the village. This guy, when he comes back from the farm, like you said, big bowl of fufu and soup with lots of bush meat, not a vegetable inside. Now, not a vegetable inside, partly because, I mean, that's not how he's been raised to, to eat fufu. But also because, as a nation, vegetables are very expensive. They seem to be the preserve of the rich. So my cousin Kwesi, vegetables are not part of his ecosystem. How do you get him, who is most likely to be among the 50% of people with NCDs that is not aware, how do you get him to change a behavior of a lifetime?
Right, so thank you very much. And I think that, Doc has said it all. The point is this, we need deliberate, so that's what sometimes I go and then kind of attack government because, if you don't have policies, then sometimes become practically very difficult, And Prof was mentioned the fact that we need to conversation has to bring in other stakeholders, food and agriculture, educational sector, and what have you. But unfortunately, these institutions or these stakeholders sometimes are missing in this whole conversation. Right, so we have been trying our best. Of course, we cannot cover everywhere. So what we do is that we try to create the awareness, let people understand that because it's the benefit of, of eating fruits and vegetables, but it's actually very, very difficult because they'll be asking so many questions. Where are we going to get the money from? I mean, even why would they have the fertilizers to even grow these fruits and vegetables, And even when they grow them, I mean, they want to sell them out so at least they can, be able to fend for the, for the family. So the point is that we need, broaden up the conversation so that we bring all stakeholders on board. The Ministry of Agriculture, Ministry of Food and Agriculture is very, very critical in this conversation. And I think that we can also leave the Ministry of Finance also out in this one, because they bring in the money. They must understand the cost and benefit of all of these things. So that at least if the Minister of Finance understands that if he doesn't provide the funding, this will happen. When people fall sick and go to the hospitals, you're going to spend more money, take care of them. So the point is you have to look at that, the cost-benefit analysis, so you're able to know where do you invest your money. And again, having said that, then it comes to prevention, because prevention is very, very important. And educating people, health literacy is very crucial, as we have mentioned. So we need, of course, to continue with the awareness creation. It should be in all aspects of our endeavors, not necessarily only on food and vegetable, but all other unhealthy commodities. Let me just mention that, with respect to the school environment, I think that's why we need the Ministry of Health to come up with policies that will regulate our school environment. Because, though children go to school, children are spend most of the time in school. I think you agree with me, because my child will go to school from 8 and then close and then gets home by 4. So they spend practically a huge number of time in the school. So if the government is able to come up with policies that will regulate the school environment, because you go to some school and then even the headmistress, the heads are those who are selling all the junk food, and what can you do? You can do little about that. But I know there are some schools that, are practicing, this, healthy food habit. I know a particular school, for instance, where the headmistress testified that indeed the children are not falling sick. They are not going to hospital as they used to do, because she has brought some kind of restrictions. You don't bring, juice to school. What they also provide is food and vegetables. If you want to take this juice and stuff, you take them when you close from school, but she wouldn't allow that, in the school. And the children are growing healthy. So we need to have a study to understand that indeed, if we're able to do this, it will go a long way. And I think that school has ever come to one of our forums, and the headmistress actually testified that when we go, the way, as Doc mentioned, we are going to reduce the extent to which our children are exposed to, falling sick and now regularly going to the hospital. So I think that for me, I've been somebody who always, come at government. The fact that we have policy, but the policy need to go to the schools, especially on our school environment, and what the children, are fed in the school. And it shouldn't only be on the school feeding program. We should extend it to the private sector as well, the private schools. So at least we know that what the students or pupils are eating in the schools to, we kind of understand what they are eating. So we're able to regulate. Otherwise, we're focusing more on the school feeding program. It's not good, it's bad, and leaving, the private school. And the worst is happening in the private school, because children are growing more obese at the private schools. Not much is being done at that level. So we need to kind of, and then also in the school curriculum, we need to ensure that we review them to ensure that it has more of, activities that would make the children grow healthy. You and I know that most of our schools now have been cemented without, playfields, which causes a lot of problems, and they're coming, also the astroturfs are also compounding the problem. I mentioned that now children living in the communities must go and pay. They don't have the leverage of playing around again, because most of the these facilities have been given private owners who are building the astroturfs. So, and you have to pay before you get access. These are all increasing our disease burden. So we need to review our strategies in every aspect of our endeavors.
So let me challenge an assumption, right? Also what you said.
Yeah.
That it's very difficult to convince your brother to get rid of the akrantia and stuff and eat vegetables. But culture is dynamic. Culture is really dynamic. Some years ago, Ghana was predominantly a vegetarian country. We ate chicken when we had Christmas.
Yeah.
Yeah. we were eating fish, but that one, you know, small amani will be shared by 4 people. It was a lot of contemporary and garden eggs and etc. And of course, we've moved forward because the fast food enterprise, they've been able to do very good marketing to convince people that, you know, if you eat fast food, it's better than eating the contemporary and amplicien. And I think in order to convince your brother, we need to have a very good story. It's not so much about don't eat akrantie, but we have to have a story. Why should your brother abandon akrantie or pork for fish or contemporary? The benefits has to be communicated clearly to your brother. You know, the change of behavior is just an outcome of the conversation that we need to have. Yeah. And I think that's critical. Otherwise, we'll be focusing primarily on the situation now and convincing someone to change. You know, somebody said that the thinking that created the problem that we have now will not be the same thinking that will get it out of the problem. Exactly. So we really need to have drastic engagement, convincing, inspiring stories to let people know that the benefit of doing B instead of A. And it goes down to what has been said already of education, particularly also at the younger age. And I know researchers really working on this to see how can you engage children. Because, you know, the children will grow to become adults, and then will have the propensity to all these diseases. So how do you engage them? And if they come home and tell their parents that, hey, I learned this in school and it has to be this, they do listen. But it's also a long-term process. You know, this conversation today is an important step towards all the contributions that, you know, stakeholders in Ghana are making. And so let's try also to put the conversation, as Prof said, in that integrated framework and see the steps that we can make towards it.
Between the three of you, you are sparking small hope for me.
Yes. So we also need to sort of drive home the fact that when we talk about vegetables, we are not talking about carrots, cabbage, lettuce, and other things. Like Dr. Kwesi said, contemporary, garden eggs, okra, what we have locally. We're talking about the different kinds of leaves. People have dandelion growing in their house. People have spinach. I mean, all sorts of things. So those also count as vegetables. So it's not just about going to the markets to say that I want to purchase this. And then also we can encourage people growing some vegetables and fruits in their homes. Even if you don't have a backyard, people are using Kufuor gallons, people are using plastic bags, people are using old buckets and things. So we can grow and then eat what we grow.
Very important. Yeah. Now, before I bring in Prof, I have a question for government. We've seen it done in other parts of the world. The United Kingdom has had fantastic success with their 5-a-day initiative. It was very subtle how they introduced it. They didn't make a law, but there was so much information about why you need 5 portions of fruit and vegetable every day in order for you to have actually nourished yourself. And that sunk in. Businesses took, you know, the cue. If you make fruit juice and you know that your fruit juice makes up 1 or 2 of someone's 5 a day, you put it on there. So someone in the supermarket has options and knows that this option will help me meet my goal. And so that option then gets more market. These little trickle-down effects from a simple information campaign has yielded billions of pounds in savings. Why don't we have something like that from government of Ghana?
Yes, Kojo, that is very true. Like what my colleagues have said, the key thing is empowerment. I mean, how do we empower the kids in schools to understand that there are certain foods that when you eat, you are more likely to get these, you know, diseases when you grow up. That is one bit of it. We also talk about the community level. The way our cultural setup is, you need to work with the community, you know, people to be able to deliver, you know, quality health services to them. So one of the approaches that we are using is the One Health framework. When we talk of the One Health framework, This is meant to ensure that all agencies and stakeholders whose activity impact on health will work in a concerted way to be able to educate the population about the effect of some of these lifestyle choices that we do. And I'm happy my colleagues also mentioned, for example, the school feeding program in school. These are some of the things that we work with the Ghana Education Service to make sure that we also educate, apart from feeding them, we educate them on the effects of some of these things, the NCDs, in schools. The 5 issues that we mentioned in UK. In Ghana, in fact, the FDA, I'll just single out FDA, is doing really well in some of these areas. We need to also leverage on the regulation. How do we ensure that advertisement, on some of these things, how do we show that they are harmful to the body system? People tend to change when they see some of these things. That, okay, you see a cigarette with a pictorial view of what you are likely to suffer from when you go on using a cigarette or consume so much alcohol. These are things that we can begin to also drum home to the population. And I agree with my brother that, behavior change takes a very long time. And the question you asked earlier, how did we get here? We have had a shift from communicable to non-communicable. As a population or country, we are aging. Rapid urbanization is also happening. And all these things come with, unhealthy lifestyles and some of these. So we need to begin to work together with key stakeholders to drum home the importance of, indulging in a very good habit of eating, doing physical activity. Where we live and work, we need to ensure that we make provision for people to exercise. And we've seen it in some places where they've dedicated a day or two for workers not to use the elevator or lift. You work through. These are little things, but that I can tell you, at the end, you are likely to benefit from it. You need to begin with some of these small things, and then at the end, we may get there.
But everything you've described, these are things people tend to do on their own, of their own initiative, of their own steam.
Yeah.
I'm looking for leadership here. I'm looking for government saying that, right, like how we did with Friday African Wear.
Yes.
Right? Yes. That was a leadership decision.
Sure.
Right? So I'm looking for that in this bid to change people's behavior.
Yes, Kojo, that is right. And we believe that we can do that through the collaboration with the Ghana Education Service. I don't want to repeat that, but that is what we believe we need to inculcate into the school, or the students, the children in school.
When?
It's starting, Kojo. We are working together with these stakeholders in this space. I mentioned to you that we formed a multi-sectorial NCD steering committee with reps from all these important agencies. And let me mention that the Ministry of Finance has also recognized the importance of these things. Like I mentioned earlier, it has effect on the economy of the country. So what we are trying to do is that for the MDAs and MMDAs, if you are submitting your annual budget to the Ministry of Finance for consideration, they need to include NCD activities in the budget. These are things that we can work together to, make sure that in all these districts, in all the communities, at least the MDAs, the MMDAs are including activities, NCD activities that they will also embark on. Aside that, within the health sector, we need to also track, the implementation of some of these things. And the surveillance system of, we are now deploying the surveillance system of keeping the hypertension, diabetes, and other, NCDs on it to track, make analysis, and make informed decisions. So these are the things that, together with the stakeholders, CSOs, our donor partners, we are trying to do. It's also good to mention that it's not just Ghana when it comes to recognizing that this is a burden. Globally, if you look at the UN SDGs, it's also acknowledged. So in terms of financing, the previous policy, one of the biggest challenge was funding. It was a major, issue. We couldn't get money to implement most of the activities that we did. Now the global, community is also recognizing the importance of this. So we want to also leverage on the bilateral arrangement that we have with our, partner countries to get funding support apart from the local ones that we have. We are also using the NHIS as one of the means of financing some of the, the cost of NCDs. We've put onto the NHIS package the childhood, cancers, about 4 of them. We have also put onto the medicine list the one for the sickle cell, which is the hydrourea, These are the things that we are all working together within the space to try and then make sure we reduce the burden, the spread, and then the burden of NCDs.
Whenever you talk about funding, the next word that comes up is priorities, right? Because really, if there's no new money coming in from somewhere, we have to figure out how to spend the money we do have, okay? So as an advisor to government, a government that has decided to build 111 hospitals, when 40% of those who are alive, who are alive today, are likely to die from non-communicable diseases, have you voiced your advice to government that perhaps our priorities should change, and that instead of 111 hospitals, maybe some of that money, maybe you should build fewer hospitals and spend more money preventing people from needing hospitals?
In addition to the preventive measures, we also admit that there are some who have the condition that we need to treat, or even early detection, and then making sure that they have a better health outcomes. If you look at some of the challenges when it comes to NCDs, at the lower level of care, the communities and the chiefs and health centers, they don't have the capacity to provide NCD services. The referral pathway is another one. Where you live, health center may not be able to provide you care. You have to be referred to a district hospital. If you live in a district where there's no district hospital, it means that you don't have access to medication or any other treatment for it. So those policies or interventions are also very important. We have gaps in those, infrastructure. We have issues with the distribution of personnel and all those things. So even though we are talking about prevention, we cannot run away from the fact that there are people who have it who also need to be taken care of. And you need some of these, interventions, health infrastructure, equity in the distribution of personnel to take care of them. Else you live in communities and then you get referred to the higher place. That higher place is not in your district. Some may not even have the transportation to go. So in as much as we are all focusing on preventive aspect, there's an aspect which is about treatment or management of the cases, which, as we speak, in Ghana, is better done at the district, regional, and tertiary facilities. Right. So you need these things in addition to the preventive measures that we are all talking about.
All right.
Thank you.
If you just joined us, this is the first Joy National Dialogue on non-communicable diseases. We've already been live on the Joy News channel and Joy 99.7 FM, as well as all our social media platforms for an hour. But we've just been joined now by our Joy Prime audience. Good evening to you all. This is a very important conversation held under the auspices of Farm Access, represented here tonight by Dr. Kwesi Bohini, who is the Director of Health Systems there. We also have Dr. Jacqueline Thompson, family physician at the Greater Accra Regional Hospital. We have Professor Gordon Abekan Nkrumah, who is with the Department of Health Services Management at the University of Ghana Business School. Dr. Eric Nsia-Boateng is the head of monitoring and evaluation at the Ministry of Health. He represents government in this conversation. Labram Musa is the national coordinator of the Ghana NCD Alliance, with lots and lots of advocacy and real-life experience being brought to bear in our conversation. Now, Prof, it is obviously cheaper to live an unhealthy lifestyle. In Ghana, a tomato costs 5 Ghana cedis. I mean, are there some Ghanaians who unfortunately are priced out of the option of healthy living?
Thank you once again. Maybe what I would do is that I would rather would not want to start answering you from there, but look at the whole financing issue holistically. And the way I see it is to analyze it from the centers of responsibility, which starts from the level of the state to corporate Ghana and then to communities and individuals. Now, the level of the state, there are 2 things that I see, okay? The state should be pressured to do policy shifts, And this policy shift could be issues of regulation, and then it could be issues of taxation to raise money. And I think that what we should be doing is strong advocacy, what I call a business case, which is woven around elite incentives. So, for instance, we have argued that NCDs are the next pandemic. Okay. How are we communicating NCDs to the elite who have the power to make decisions when it comes to resource allocation, say the Ministry of Finance, say Cabinet? How have we communicated NCDs to them? Do they see NCDs as the next COVID, which is coming up, which may necessitate the president having fellow Ghanaians every fortnight and having meetings all over the place? So the way we package this message and carve it around their own incentives in terms of how this determines their electoral fortunes would be very, very important, because these are the very things that sort of tickles them to reallocate, to create the necessary policy shift. For instance, if it is about regulation, to be able to push down the junk industry, and if it is regulation, to raise new taxes. Think about it. COVID, we came up with 1%, was it 1%?
Levy.
Yeah. And
we still pay.
And we still pay. And we all paid without, because everybody saw what COVID was doing. And so we need to think about it this way. Then the other side is resource allocation. Again, I think that the civil society space, together with the Ministry of Health, should begin to develop the capacity to make a business case in a way, again, that is aligned to the incentives of the elite, both at the state, subnational, and even at the district level. We need to begin to look at this so that there can be shifts in resource allocation. Now, when it comes to corporate Ghana has a role to play in these conversations. But I think that there is the need for policy levers that create incentives for corporate Ghana to begin to also support the process. Because remember, they are not Father Christmas. And so policy can be redirected to create the enabling environment and the incentives for corporate Ghana to get into this. And again, regulation in that side. And then I'll come to the side that you are most interested in, the average Ghanaian and a tomato costing 5 Ghana cedis and how many people will be able to buy. So I look at this from two directions, okay? I think that first is about issues of responsibility, okay? We need to have a big conversation about responsibility and where this is taking us. I mean, I don't think that before COVID, any of us was interested in washing our hands and having a mask on. But when we knew COVID was going to kill us, majority of us decided to put on the mask. Of course, I don't expect everybody to put on the mask, because in every society, you're going to get a few deviant ones anyway. So how have we elevated this conversation? And if we begin to go that direction and begin to let people understand the personal responsibility that they have and the payoff for that personal responsibility, my thinking is that behavior will change. But again, I also think about support systems. So let's talk about planting for food and jobs. It was a big policy. We all talked about it. But I think that that is a lost opportunity. Planting for food and jobs could have been aligned with an NCD strategy such that households are being supported with subsidized organic fertilizer, seedlings, and being given the education and training. That education does not mean you should come to my house. Think about, they were doing math and science something on TV. There can be state sponsoring that, teaching people how to do home gardening. Kojo, if you come to my home in University of Ghana, there's, the dispenser bottles. I just cut them and just get soil into it. And when you come, I'm planting almost everything. I have people can do, even those people who are using the tiles, they can still plant basic vegetables. Okra can grow very well in that. Cocoyam can grow very well in that. Garden eggs will grow in that. And so it's not an issue of saying it is just 5 cedis and so I cannot buy. But people can be encouraged and supported at home to do this. And what's going to happen is that it can even generate income for people. And as it generates income, it also gives them some at home to eat. And so for me, I'm not the sort of person that looks at constraints. And so I'm a bit biased because in my world, I don't see impossibilities. I always see that there is a possibility, but there's got to be personal responsibility and then support to be able to deliver that.
Just out of curiosity, what on record is the mortality rate for diabetes alone? Out of all those who have it, what percentage end up dying?
I mean, that is a challenge that we face. I mean, if you look at the routine database, in our last health summit, which was organized in May, we tried to estimate that from the routine database. And I can tell you it was just less than 1%. But if you go into the WHO website, it's between 20 to 30% for those aged between 15 to 49 adults. These are estimates that we have it in the state. And it's one of the issues that we also want to address. How do we make sure that we have a system that collects the information for us to routinely analyze and make informed decisions of those things?
I want to work with that estimate because of the question I want to ask.
Let me say this. I am likely to believe the WHO estimate because the study, and you know that diabetes and hypertension, they go together.
Yeah. Yes.
Okay, and the study in Ghana estimated around, in terms of those who have hypertension is between a lower end of 26 to about 34%.
Right. Yeah. Okay.
Yes.
So if we're looking at some 2.4 million, according to WHO, people with diabetes. I'm focusing on diabetes for just a moment because of the question I want to ask. About 2.4 million people according to WHO. And if we're saying about 1% of them will die or are dying, that's what? That's 24,000?
Exactly.
24,000 people. Okay. Now, 6,700 people die from smoking. Smoking. 24,000 die from diabetes. Why in God's name have we not put a warning on every product that contains sugar?
It's something that is being done, and I'm sure we are all aware what FDA is doing. Recently, there was a court case that when they tried to prevent the celebrities from advertising for some of these alcohol. Exactly. So these are measures that we are using the regulatory framework to also try and curb the increasing rate of NCDs. Yes, so we will get there in terms of having pictorial views on some of these things. Yeah, so I am happy we've started.
What are the sort of the hurdles? What are the obstacles to doing it now?
Kojo, you agree with me that some of these things you need to involve the stakeholders in that space. For the manufacturers, those who produce this, you need to bring them to the discussion table to let them understand. Well, they are looking at the profit side of it.
We didn't have to do that with tobacco.
Exactly. I mean, so they are looking at that side. We would then be looking at the life of the population. That is what we are interested in. How do we protect them for economic gain? So these things will require discussion when it comes to the legislative issues that you talk about. So it's a discussion that we will continue to have. We have begun with a ban on some of these things, and we continue to engage them and push forward that, going forward, if there's a need for us to have those scary pictures on some of these things, why not? If we believe that is what will address some of these issues, to drum home for people to understand that if I indulge in some of these things, I'm going to get this. Of course. like the COVID thing that Prof mentioned, when we all saw that the fatality rate was really, really, quick, no one will tell you you need to put on a mask to avoid getting it or contracting it. So apart from educating people, I believe that some of these regulatory frameworks can also help us to address the incidence of NCDs that we have in the population.
What's your assessment, Dr. Thompson, in terms of regulation? Are we a bit timid with regulation? Are we a bit slow to make the bold moves that will save lots of lives in one go? Or in your experience, because I ask you this because of your direct interaction with those who suffer and die from these conditions. In your experience, is it about time we got radical with our legislation around it?
Yes, I think it's about time. The time is now. I think we've waited for quite a long time to, start this or put policies in place. I mean, the policies are there, but then how to implement them. If you go online, you'll find out there's a policy on NCD. We had one from previously, and then the most recent one was done in 2022. In there, you will find that we have to bring about diet, we have to control things, we have to do physical activity, we have to do this. The whole plan is there. But then why are we not implementing it? And it's got to do with the policy makers are there, but then we have to make sure that it is implemented and carried out. So if the policy is implemented and you find people are defaulting, then what are the consequences? Okay, so it is right about now that we have to put those things and stamp our feet down and say that we need to do it. And for us as healthcare workers, we need to come up with patient stories. We need to come up with figures. We need to have evidence. We need to have the data and put it across and say that this number of people who indulge in this activity or this behavior either benefited from it or they got a risk factor or they died from this or whatever it is that they gained or suffered from it. So it's right about time that we need to put these measures in place and make sure that it is done. Because in certain countries, excuse me, like in Singapore, I watched a documentary recently that talked about the fact that their human resource is the most important thing that they have. They don't have anything else. So they made sure that they will make physical activity spaces available. So you find 70-year-olds, 80-year-olds who are exercising because those are made available in their communities. And then what are we doing here? We have to get radical, like you said. So we have to move on from advocacy and we have to get active. We should employ the activism and then get it going. And we all have a role to play. But I believe that as a healthcare worker, if I'm not giving the information that this is what I found, even if there's data and we are sitting on it, or the data is being generated and it's not being put to use, then there's no point in even generating the data.
Labram, sorry, you had an intervention.
You've asked several important questions, and I guess, when I came in and I saw we have 3 hours, you thought it was too long, but the questions are it's too short. Yeah, I now get the impression that maybe it's too short, because you're asking critical questions which may require a lot of time to unpack. So the first, one of the points was more about the financing of it, and I think Dr. Prof made a point about building a business case for it. And investment case is critical, because also Dr. Thompson said, we are not talking only about individual health. We're talking about the economy. We're talking about human resource for health. We're talking about the social fabric that many people are moving to the cities. So really having time to articulate such an investment case is critical. Based on the nature of my work, I analyze challenges in the context of looking for solutions. Yeah, and I think, I was at a conference in Koforidua, and this was a conference of the Christian Health Association of Ghana, CHAG, and the CEO of NHIA was there. And so I was talking about leadership, and he said that one of the things I heard him say is that when you have your birthday, NHIA will provide free of charge checkup.
Yes.
I think it's important that he said that. And it's also important that people will take advantage of it. One of the important developments that have also happened, so before COVID, Ghana and Norway, they had a policy on NCDs. And this was signed for the first time across the world. This was signed by the Minister of Finance and the Minister of Health. Yeah. Because, health will hammer on that we need to do something, but the money should come from somewhere. Yeah. And so the fact that the two entities came together to sign that, it was a recognition that, outcomes should be financed. Mm. Fortunately, we have NHIA, and also in my view, the fact that the government is paying 70% of the cost through tax. And so we have all these building blocks. The point is, how do we engage to get the maximum out of it? Technology is critical. Because, as I said in the introduction, you've seen how it's transformed finance. So coming to health. And I'm of the opinion that due to economic challenges, every country has limited resources for health. That's the reality. So we can say that there should be more money to health. It's not only here. It's in the Netherlands, it's in Rwanda, it's everywhere. So given the limited resources, how do we then use technology? And I'm also a firm believer that you can actually provide more and better care with limited resources. Because when you put technology in, you should be able to target people who really need NCD care and effectively. If you're doing campaign, technology can help you to target your efforts. In addition to the fact that when you use technology, you get data. Data into, we are all happy. Happy is not a word, but it's important that we know that 43% of mortalities are from NCD. Is the data. Data gives you the epidemiology. Data gives you how people utilize care. So if you are doing campaign and nobody is using it, through technology you will know. And that can also help you to target your intervention. And above all, when you have data, it can also help you allocate resources. So I think we have to look at the efforts that has been made and how we add, build on those efforts, optimize the capacities that we have. And of course, it's also been emphasized all the time that this is a long-term effort. And I think starting with this conversation, is the way to go. But let's also recognize that if you are engaging, engage people on the basis of what have they done right and how can they improve upon it. Talking about your brother and Fufu and others, so this morning he didn't eat. Well done. How can you extend it? So not totally coming with something out of his or perspective. It won't work.
Okay. We spent quite a lot of time talking about diet, which is such a big pillar in the management of non-communicable diseases. We'll also come now and talk a bit about exercise. Then we'll talk about medication, which is about dealing with those who have it, the very important point that you made, Dr. Nsiah-Boateng. And then, of course, all through this, it is quite obvious that there is a massive lack of data. We've done some good work, but we need to also try and figure out how to improve on our data going forward for decision making. So I want to start off the conversation about exercise with you, Labram. And an important point was made earlier in Dr. Boahen's introduction. He talked about how the increase of urbanization has resulted in a certain sedentary lifestyle which is not very helpful in the management of NCDs. I'm curious about that. First of all, perhaps still about half of Ghana is rural. In spite of all the urbanization, about half is rural. We also admit that about 50% of those with NCDs don't even know about it, which means they are likely to be the ones who don't have access to healthcare, which means they are likely to be rural. But are rural Ghanaians really that lazy? These guys are going to the farm every day, they are carrying, firewood on their heads. And can we really say that we have a sedentary lifestyle problem in rural Ghana?
Right, so thank you very much. Well, for sedentary lifestyle, I think that it might not be very pronounced, in the rural areas. The rural folk definitely will have, but it will not be as much as, the southern part of the country. But I love the conversation around whether, we are bold enough, and I think that I want to just touch a bit on it, and also
Sure.
the financing. I think that we call it, we are not bold enough, to take some bold decisions. In Rwanda, for instance, you would find how they have an initiative where they could say, park your car. So every Saturday, from morning to 5, just park a car. You don't use your car, you have to walk. So they encourage physical activity, and you have the whole nation, in support. Like that kind of mass movement. That for me, I call that leadership. And also, this kind of leadership that the Director General for the WHO, Tedros, he's also championed this walk the talk. So at many events, once he's there, he dedicates at least a day or two for physical activity, and you have everybody, massing up, to do that, So the point for us is we need that kind of, and I also appreciate one of your guys who work here. You see him mostly at from my Mensa towards PURC.
Lexus Mill, yeah.
Sometimes I follow him, and I think that we need to encourage more people to do that. But of course,
when they climb the hill and they get there, they eat kinky.
That is the most unfortunate. That's the most unfortunate part, because we even have now people selling alcohol, and all manner of things, on the street. So the point for us is, at least, we are doing very well. We need to educate people that don't go and exercise and then you go and eat, a bowl of kinky and all the things that you are trying to, kind of ban, But again, about the issue of the boldness, and then whether we are, our policymakers are actually looking at, what we need to do to ensure that we are bringing everything on board. So, for instance, we are having new roads being built, right? And because of these smart cities, right? And trust me, most of these roads are lacking the very things that modern roads are supposed to have. So sometimes I expect the media to be asking all these questions. So the new roads are building. Can we see the architecture? How are we building the things that people need to have to be able to kind of exercise? And then, whether you are having pedestrian walkway, the motorcycle way, these are things that we need to bring. But of course, so once we are building the roads, they might come. At the rural setting, for me, I think that, as you mentioned, they do a lot of the exercises. The challenge for us is, they are also challenged with these kind of fast food joints, and these are homegrown foods. We don't find these indomies and stuff being sold in the mornings. We find them in the evenings, When you are going home, people buy them and then they go buy sleep. And these are happening, in our communities. And that's where we also felt our law enforcement agencies, the FDAs, to up their games. Because by 5, everybody closes and go home. So who check, those who operate at night? And that's where the burden increases. Because people, eat all manner, come and set up and sell all manner of food in the evenings. And nobody check to ensure what they are selling is a healthy one or not healthy one. So I think that the conversation needs to be brought in. We need to finance the law enforcement agency so we can have those working at night and those also working, during the daytime, so that we don't have, this kind of attitude where people think that, and they also, run away from paying taxes, because when you pay night, nobody come and worry you with tax. So we need to, broaden this conversation, bring all other actors on board, and then holistically look at how do we ensure that we are able to target the real problem, because the real problems, are there. But sometimes because, during the day you have some people and you target them alone, and leaving those who, are the main corporate that you need to target. I want to touch also on the financing bill that I mentioned earlier. You know what happened in Parliament, for instance, when we're advocating for the, taxes on excise taxes, for instance, on healthy commodities. The hell that, we went through. Just to, have, policymakers, Parliament pass, an excise taxes on healthy commodities. Commodities that are injurious to our health. The prices are very cheap in the market, as compared to other countries. In fact, they know that the products are very injurious, so they put taxes on them. You buy a cigarette at the cost of $20. Can you imagine how much that is in Ghana cedis? But here you go to the market and very, very cheap in the market. So the point for us, that's what we call about financing non-communicable diseases. And I just ended a World Health Assembly, in Geneva, for instance. Most of the discussion were on how to finance non-communicable diseases. And many of the case studies has been that, we are not tapping on the right resources. Because the point is that the donor is becoming fatigued. So we need to look internally, where do you get the money from? The very product that's giving us challenges, the suggestion, recommendation has been that let's tax them so that we use the money, not necessarily to get funding, but we call them byproducts of taxing this product. It has so many things, upon the fact that prices become very, very expensive, kids are unable to access them, even the poor and vulnerable are unable. The rich man, it's okay, let him be able to buy it. When he falls, he'll be able to take care of himself, we say this, but the poor and the vulnerable, let's keep the prices a bit, higher. The sugar-sweetened beverages are just very cheap in the market, so they're able to access them. So, but when they're expensive and the poor man is going to buy them, he would think, twice before he, So we are urging our Minister of Finance in the mid-year budget, if possible, they should review the excise taxes on healthy commodity and then up it a bit more, so we can get some resources and then channel them to the health sector. A country like Chile, Mexico, the Thailand, they have a case study that we can use where they are using these resources to finance the national health insurance, and we can do it.
I often, I'm sorry, we have to take a break. I do often tell the story of how I became diabetic. For about 4 years until my diagnosis, I hadn't drank a single drop of water because I was living in a community where juice was cheaper, Fanta was cheaper. So. Yes, I take your very important point. Listen, if you've been watching us on Joy News or Joy Prime, or listening to us on Joy 99.7 FM, or perhaps on our social media, we want you to keep your thoughts coming through. We're going to take a break, but I have a question for you, okay? Answer me honestly. This morning, you probably took a car to work and a car back home. You've probably already had your dinner since it's almost 8 p.m. Tell me this. How far have you walked today? And what did you eat for your largest meal? Let's assess how healthy we are on a regular day. We're back with more on this Joy National Dialogue after these messages. You're welcome back. This is the Joy National Dialogue on Non-Communicable Diseases, the silent epidemic. This dialogue is held under the auspices of Farm Access and NORAD. Our guests, Dr. Jacqueline Thompson, family physician for the Greater Accra Regional Hospital. Dr. Kwesi Boahene is the Director of Health Services at Farm Access. He, of course, was with us earlier. Professor Gordon Abekan Krumah is with the Department of Health Services Management at the University of Ghana Business School. Dr. Eric Nsia Boateng is Head of Monitoring and Evaluation at the Ministry of Health. and Labram Musa is National Coordinator of the Ghana NCD Alliance. We have covered quite a lot of ground. We are live on the Joy News channel and on Joy Prime, as well as Joy 99.7 FM. We thank you for staying with us thus far. We're also live on social media, so you can follow us on our live broadcast on Facebook as well as X and YouTube. Now on X, we want you to be a part of the conversation, so use the hashtag #JoyNationalDialogue as you make your contributions. We will share a bunch of them later on the show. We'll also take your phone calls if time permits. In fact, we intend to take your phone calls. So get ready with your questions and contributions. We will do that as the show progresses. Now, we've done a lot. We've talked about diet, which is one of the big pillars in the management of non-communicable diseases. We started a conversation on lifestyle and exercise just before the break. And Prof, I'm interested in this because, I asked earlier, Labram, about the issue of, rural versus urban and whether indeed we can honestly say that the rural Ghanaian is living a sedentary lifestyle. I wonder what your research and learnings tell you about that.
All right, thanks very much. So I am not too sure that the issue of sedentary lifestyle is a big issue in the rural area, because I think that it's about going to, if you've lived in the rural area like I did when I was young, getting up, going to farm. It's a lot of activity, walking over long distances. But I think that the issue of rural area is more about their diet and then the issue of toxins. So, yes. So, for instance, if you talk about those in rural areas, high consumption of alcohol, which is a risk factor, those who are also smoking, and then of late, the different aphrodisiacs with herbal medications, and people use it without any prescription and things like that, different concoctions. That's important. And again, look at the issue of galamsey. Galamsey is mostly in rural areas and not in cities. I'm not too sure whether I found any cities with galamsey. And I remember, I think somewhere last year, I was talking to a medical doctor in the Western region, and was talking to me about what she described as an epidemic of kidney disease. And basically, if you look at it, the only thing you can think about is galamsey. Again, you're also thinking about the issue of chemicals used in agriculture without the necessary supervision and regulation. So these days, instead of people weeding, they're using herbicides. I'm not saying that herbicides is a problem, but I think the issue is about unregulated use of herbicides, and even those doing vegetables. Look at the amount of fertilizers they are pumping into vegetables, the amount of chemicals they are pumping into vegetables to control pests and insects. And all these are major risk factors that are also related to NCDs. And so I think that for those in rural areas, the major issue is about how do we handle and treat them when they are diagnosed. And I remember earlier on, Dr. Insian was talking about the fact that we do not have the requisite personnel and equipment at the lower level, which is very true. But I think it's at this point that we can innovate. And basically, one of the things that I'm learning from my new found love, let me explain, because maybe my wife might watch it so that she doesn't think it's something else. My new found love is my new research. Basically, within health policy, we've been talking about prioritization over a long period of time. But I've been raising theoretical questions about to what extent can you prioritize? At a certain point, there is nothing you can do. And so what is the next level? And the way I'm answering that question is through technology. And I think we can use technology to do a lot of things. There is this example of Devi Shetty from India, who is tackling the issue of cardiac issues from India. And Shetty is actually educating MOs, medical officers, house officers in rural areas to be able to diagnose, basic cardiac issues, and also connecting rural facilities with his teaching hospital, and specialists at the teaching hospital work with those in the rural areas based on medical technology or transmission technology to help them to be able to diagnose and give basic treatment. And in fact, those that they cannot treat, they will be the ones to refer so that things don't get out of hand even before they come to them. And so we can use technology to address this. But let me also say, Kojo, I remember you were asking Labran about the issue of, so we did this for tobacco. Why are we not doing it for...
I was actually asking Dr. Nsiamboati.
Yes, why are we not doing it for...
sugar.
Sugar. We need to understand that this is politics, okay? Because these corporations are big corporations that control a lot of resources. So there is a political economy around those issues. And so if we think that the state will just act, it may not happen. There is the need to exercise a certain level of agency. And I think that what we saw in Kenya, at least, has taught us a bit of lessons that there is a certain level of agency. When I say agency, it's not UR, I mean AG.
Agency.
Yes, agency, okay, about with the people. And so it means that we all need to be part of this conversation and let our politicians, those who make decisions in Parliament, understand that we are at the crossroads and we cannot begin to look at NCDs as business as usual. And until those sort of things happen, it is unlikely that the policy shift that we require will happen. Because remember that these corporations are big, their tentacles are huge, and they are very influential.
Very important point. I want to come to you, Dr. Thompson, while we're talking about exercise, right? This text message came through from one of our viewers. She works from home, okay? So she first tells us what she ate today. Okay. She's had Tom Brown, she's had banku and okra stew, she's had palm nut soup and a bread roll for dinner, okay? Now, for exercise, she says, and I quote, for exercise, I've gone downstairs more than 20 times today. But I hear that cannot be regarded as exercise because this is something I do every day, so the body is used to it, and I don't do it vigorously either. Talk to us about the reality of exercise and people's opportunities to exercise. In the consulting room, do you find that this sedentary lifestyle, is something that the average Ghanaian can actually turn around? Do they have opportunities to do so?
Yes, thank you very much. So with the concerning the text message that you have, and then she talking about the fact that she's gone up and down the stairs 20 times today, it's got to do with how long did it take her to do that up and down for 20 times. And if it's something that she does every day, of course the body is used to it. So we call that, that will be regarded as physical activity, okay? So she has not been sedentary the whole day, because what is required is that you do, when you're doing exercise, you will do 30 minutes of medium intensity to vigorous intensity of exercise. And the difference between physical activity and exercise is the fact that exercise is more intentional so that you gain from it. Okay, so yes, you can engage in physical activity, but it may not necessarily be exercise. So she can be considered as not being sedentary, so long as, she's going up and down the stairs. When we say sedentary, then it means that for most of the part of the day, you are seated or you are lying down and you don't engage much Of course, we do some physical activity. I could walk to the door. That's considered as physical activity because I'm not sitting down. But for how long do you engage in physical activity to consider it as exercise? How vigorous is the activity that you are doing so that it will be considered as exercise? And when you engage in that, that is when you gain the benefit from it. So we say that you are doing physical activity so that it becomes exercise and then you benefit from it. And of course, yes, from the consulting room, I usually would get patients, when they come, you ask them about their physical activity. And of course, we are living in an urban area where currently most people live far away from where they work. So they have to wake up early in the morning. I'm a typical example. I wake up very early in the morning and then I have to go to work. When I get to work, go and sit down, wait a couple of hours, then I have to start my work. So, I mean, that's the same for most people. You sit in the car, drive for an hour, go and sit down in your office or consulting room. And if you have a lot of work to do, whether it's paperwork or seeing patients, you probably won't get up from your desk to go and do a physical, to engage in physical activity. So then you tend to be sedentary. So in order for you to break this sedentary pattern, what you can do is, if I have to go to the door, to go and open the door and call the next patient to come in, that's using myself as an example, that's engaging in physical activity. Instead of probably pressing a bell for the next person to come in, or just say that I ring the patient so that when the first person comes in, then the next person, you see the patient off to the door and then open and then let the next person come in. That's physical activity. If you are too busy doing paperwork, sitting at your desk, when you're sitting at your desk, moving your legs up and down whilst you are busy doing whatever you are doing, or taking breaks, or to stretch or do certain things, those are the things that you can do, and then you are engaging in some physical activity. It may not necessarily be exercise. Okay, and another thing about exercise is, let's say, for example, this morning I woke up and then went for a walk. I went for a 35 minute brisk walk and then went back. But if I go back to work and then I sit at my desk for the whole day without even getting up for at least 15 minutes every hour, it's considered as me being sedentary. Okay, so that is the problem. So most people who are working, who have, let's say, white-collar jobs, they are not really engaging in physical activity because of these things that I have mentioned a little earlier. So it's taking the opportunity, having the knowledge that even though you may not be exercising, you should be able to engage in some physical activity throughout the daytime. Even if you can't do exercise during the daytime, when you go back home, you may have the chance of doing some exercise. So if it's required that you get about 150 minutes to 300 minutes of exercise every week, supposing you're doing a little less than that, it's something that we mentioned earlier on that, okay, you are doing this, how can you improve on that? So that even when you are sitting down and you are doing a few movements, that should count. So I think that we need to make a deliberate effort, and it all comes down to, as I was talking about earlier, that it boils down to the individual. Let's start as individuals, let's start as families, let's take it on to the community and to our workplaces, that it is possible for us to engage in physical activity and even sometimes have exercise. There are other places where probably on Fridays there's a workplace exercise group. Okay, so on Fridays everybody brings their exercise gear, they exercise for an hour, and then whether you shower at work, if there's a shower there, or you go home and then you go and then freshen up. So it's something that it's an innovation that we can introduce at our workplaces and also in the schools. I'm not sure how long they have physical activity for PE. Okay, so maybe it's 30 minutes of exercise that they are having. But let's allow the children to run around. When they come home these days, the children want to sit down and then look at the screen. The screen time is causing a lot of problems for us. So people have bought toys for their children to play with. They have a ball, they have a skipping rope, they have their bicycles. Let them ride the bicycles. Sometimes you say the children need a bit of supervision because you're not sure of how the neighborhood is like and things like that. sometimes, yes, you may not be able to, but okay, if they can ride a bicycle just in the front of the street, you just have to take, if it's just maybe 10 minutes or 15 minutes of your time, I think it's worth it. You know, if you have to go and stand there because they are younger children and then you're afraid that maybe a vehicle may come, and then let's just put in that time. And even as you are watching them, you are also moving around, and that's the time that you take the opportunity to also engage in some physical activity. So when we start this little by little, and then also we make sure that our policy makers put this in place and then it is implemented bit by bit, we should be able to get there. And you're not going to wait for tomorrow. You're not going to wait and let's say, okay, let's start this in August or September. Let's start it from this evening.
From this evening.
Yeah.
Let's not waste any time. You know, every time I come to you, I'm wondering, when are we going to do this? Why aren't we doing this? Because it seems to me as if we're not trying to solve a new problem. It's a problem that has been solved, or at least they are working on solving it much better than we are in other parts of the world. Now, something Dr. Thompson said about children having the chance to exercise and the screen time. I have a 14-year-old son who can disappear into his screen for hours on end if I let him. Now, sometimes I want to just tell him what my father told me, which is go out and play. But when he goes out, there's nowhere to play. My entire compound is concrete, you know, for me to park a car, you know. So I'm wondering, look, is there a real way in which, I mean, you can't do everything yourselves, but you can work with other government institutions to put in little regulations? You know, that you have to have a certain amount of greenery around every home. And you put it into the zoning law, so that if you are building a home and you take your plans to the local authority and there's no green, it won't be approved. Can we do little things like this? Can we, give little incentives to businesses that have showers in their workplace so that people can ride their bikes to work? Can we do these little things? So we're not passing a law that says you must exercise 30 minutes a day, but we are making it profitable, advantageous for people to do so.
Yes, thank you very much, Kojo. It's possible, and I think over the years, for those who have maybe unfortunately found themselves at the stage where they need rehabilitation, I remember we passed a law to make sure that government institutions, especially the health facilities, also make room for such people to have easy access or passage to where they can get care. And we were able to do that. If you visit most of the health facilities, you will see that the staircase has a part of it being leveled up for our brothers, mothers, and sisters who unfortunately find themselves at that stage to be able to use it. In terms of the physical activity, I would say that maybe we are not seeing much, but I can tell you that some government institutions have gyms that the staff can go there and exercise. Some have even employed instructors to take staff through it. There are places where, I mentioned it earlier, that they've made a deliberate attempt that certain days, maybe 2 or 1 out of the 5 working days, we are not using the staircase or we are not using the elevator. We are not using the elevator or the lift. Everybody is using the staircase. These are the little things that we can, at the institutions or institutional level, we can encourage employees to practice. Making it a policy, like I say, it may not be a national level policy, but at the institutional level, management of the institution can, make that deliberate attempt.
Why not, though, Doc? Let me give you an example. My sister, my little sister, is an occupational health physician.
Yeah.
First of all, she couldn't become that in Ghana. As you know, there's nowhere in Ghana where you can train to be an occupational health physician. She had to go outside the country. Now, she's one of the very few occupational health physicians in Ghana. But that's because there doesn't seem to be a demand for them. What would stop the Ministry of Health or the Ghana Health Service or any, relevant institution ensuring that every company that employs more than a certain number of people has an occupational health physician? or has the access to an occupational health physician, so that certain, bad practices in the workplace, I mean, I've been corrected on my posture 100 times, but these little things, all of them lead to, conditions that we now have to spend money to treat. What stops government from, enforcing some simple regulations like this to ensure that all of us are a little bit better protected?
Yes, I agree with you. The guidelines do exist. And I believe in some of the institutions, we even have occupational, health units to ensure that some of these guidelines are followed. But it comes back to the attitude of, some of these employees. We may not be seen to enforcing the regulations to make sure that people go through that kind of a routine. It's something that I believe, once it has come to the attention that NCDs are on the rise, we need to revisit that. It's not something that we have to go back and develop new ones. They are already there. It's just about enforcement, like you said. So it's something that we need to, talk to ourselves and say that it's time for us to begin to implement those guidelines that we have for occupational health. And I want to touch briefly on what Prof said about the low-cost interventions that we can do. One thing that I think we can leverage on is the strong expanded program of immunization. And in fact, it was really, really helpful or significant when the COVID situation happened and we were fighting it. And Ghana is considered as one of the countries that was able to successfully fight this COVID. If you go to the communities, what we are using to try and get some of these low-cost interventions is the community health nurses. If you talk of hepatitis B, it's one of the leading causes of liver cancer. And liver cancer is also one of the NCDs that we are talking about. And these are the professionals who go into the hinterlands to make sure that they vaccine people against hepatitis B. The same can be said for the children with the sickle cell disease. The pneumococcal vaccine is also another thing that we are also trying to employ. So there are some low-cost, intervention. Maybe what is missing here is the use of technology, as Prof said, which we need to also look at. How best do we do that? We've seen the zipline drone services trying to help in that area, but I think we have to do more to address that. So these are the things that we are also making sure that we are implementing to address the burden of NCDs in the country.
Labra, I'm listening to Dr. Nsia Boateng. Do you feel satisfied that we're moving in the right direction?
Right. So we've always have our own banter. With the ministry for years. Of course, the ministry is doing what it can do. To support interventions as far as health is concerned. We also have our own, proposals, our own recommendations that we think that the government should, take in consideration, ensuring that we're able to reduce the burden, right? So, in fact, so we hear good stories from the Ministry of Health, what they're doing, and of course, we are seeing some progress, but I think it's very slow. We need that kind of, energy, to ensure that we're able to get things done. As much as we can. Because some countries are moving, very fast, and I think that we are still challenged. And as you can see, many people living with NCDs, for instance, continue to complain about, the extent to which they are unable to access, quality healthcare at the hospital. So you would find people go to the hospital, yes, but this issue of co-payment has always come up because no person living with NCD is able to go to the hospital and get everything that without paying anything. You definitely have to, to put your hand in your pocket, to bring out some money to be able to access the care that, you're looking for. And this is actually because of, our inability to stock the hospitals, with drugs. There are instances where, because I work with patients a lot, we get a lot of complaints. Sometimes we have to, try to finance their medical bills because they are unable to, the National Health Insurance is unable to care for everything that their needs, what their needs requires. So yes, so for me, one of the critical and recommendation that we always give government is to ensure that there's this kind of, connectivity between the health facility and also the ministry, if possible. And I know that Dr. Nsia will tell me that that's why the network of practice is currently being rolled out by government, to ensure that we are able to connect the facility, so facility will be interacting among each other to reduce these issues of, out of stock and everything. I think that we also need that kind of mechanism, accountability mechanism or monitoring mechanism, where, when, the policy maker, at the Ministry of Health, is able to tell that in this facility, in my village somewhere in Paha, there are no drugs there, and ensure that the drugs are, goes there. So, we need to do a lot. This is what we call health system strengthening. So we're able to connect the facility to the facility will be speaking to each other, and then the ministry is able to sit somewhere, just as Prof mentioned, we can use technology to reduce the extent to which we are struggling with non-communicable diseases. The ministry should be able to sit somewhere and then look at the computer to be able to tell, okay, fine, here we are going to run out of stock. How do we ensure that we are able to stock them? Because that's one of the major challenges that we are having. And the ministry will tell you that they are not challenged with some of these things. The medicines are there, but practically you go there, the medicines are not there. And I think there's one thing that policymakers, mostly unified civil society, talk about them, the issue of allocating the national health insurance, allocating the monies that we pay that has to go to national health insurance, which is not going. So for instance, we have
the capping of the
and I think this should be a conversation that we need to be having, because currently I'm not sure the Ministry of Health can tell us how much they spend on non-communicable diseases. In fact, we've tried that severally to know whether even if the ministry even have a budget.
Can you tell us? Do you know how much we're spending on NCDs? Let's see if we can find out right now.
For years we've been battling with that.
I want to see if perhaps we can solve that problem now, year-long problem.
Of course, we have a budget for that, because once we are providing care or we are implementing interventions to address these things, all these things require funds.
So how much did we budget for it in 2024?
I don't have the figure now, but obviously we have a budget for it. Okay. If you talk of from the preventive measures to the treatment or management of it, it's all about funding. So if you don't have a budget, it will be difficult to be able to take up.
I know your colleagues are watching us. This is information we could really do with. If one of you can look it up and text him the answer. We would like to know by the end of this show exactly how much for the year 2024, how much was budgeted for the management of NCDs. Let's figure out exactly how much of a priority it has been so far for our healthcare system. Please continue.
Right. So, and then, then the Ministry of Finance, as I mentioned earlier, we need to get them on board because per the Abuja Declaration, we all know that the 15% of the national budget to go to the health sector. But trust me, I'm sure the policy man will tell us that they're not receiving that percentage. So if you are not receiving 15% of national budget going to the health sector as recommended, as recommended by the Abuja Declaration, that means that how much we even go to non-communicable diseases. And I can tell you for a further years, we have asked severally, and that we are not getting the actual figure that government is spending on non-communicable diseases. So, and that's why we need to do this kind of studies. To once we're able to know how much for a year, would go into non-communicable diseases, then we are able to know, how to actually look for the funding. I know at the global level, they will tell you that about 1 to 2% of global budget going to non-communicable diseases. The priority for non-communicable disease is very, very low. It's extremely very low, and government will tell us that it's very expensive to finance NCD, and sometimes will tell you that it's actually the disease of the rich. It's a lifestyle disease. Once since you want lifestyle and you got in the disease, you should go treat them. But the point is that it has gone beyond just lifestyle disease. Because non-communicable disease, I define it as a disease that is no respecter of, of person. Our parliamentarians are struggling with the disease themselves.
Yes.
Every now and then the drugs that they take before they come and sit in parliament, only God knows, and everybody is struggling with it. Children, everybody. So I think that we call it, we need to put in the conversation, we need to be frank with ourselves and say it as it is, then we'll be able to then people can come in to support the intervention. I know our president is, at the global level, he's touted one of the eminence, for sustainable development goals, and even non-communicable diseases. The first global meeting, for heads of states on NCD, for instance. He's actually one of the leaders, including the WHO and also the government of Norway. So the point is, at that level, you can say that the energy is there. But when it comes to in-country, then it becomes problematic. I remember we met with the presidency together with the Red Cross somewhere early part of this year. And one of the recommendations we made to the president, if he can, make non-communicable disease a national concern, within his outfit. I think they were that kind of laugh over it. I think one of the things that they mentioned was how proactive he was during the COVID time, and we could all see that COVID was virtually taking the lives of people living with non-communicable diseases. So let's have interventions by the presidency, so at least we can have. At least he can do this for probably before he leaves office. I think that there's a call already at his office, and now we are also pleading with him, because once we're able to do that, the whole nation will rally around, because it's killing everybody, and everybody is dying out of this disease.
Sorry, I want to make this intervention about the budget. The way the health budget is drawn, we've moved away from the disease-based kind of budgeting to program-based. So one amount is given or allocated to the health sector is for service delivery, and this is an integrated system. So it will be quite difficult to say that I'm allocating this amount of money for NCDs. It's just, for example, at the Ghana Health Service, where we have the NCD Prevention and Control Program, that a certain amount will be given to the program officers or secretariat to implement the activities. But at the national level, it's not based on disease that I'm giving this so much to this. Yes.
So maybe you can just tell us how much was given to the program.
Sure.
Yeah.
Sure.
Yeah. So I'm sure your colleagues.
Then maybe on the spending, the health spending. He mentioned the Abuja Declaration. Somewhere 2010, 2011, we're doing about 11 to 12%. But for the past 5 or so years, we've hovered around 7 to 10%. And we know it's a challenge, but we are also trying to see how best we can close that gap. Thank you.
All right, thanks for that. So yes, please, if we can get the information on how much is being spent on the program, the NCD program, that would be fantastic. All right, so let's now move from prevention to treatment. Everything we've said so far about diet and lifestyle, it's all been geared at improving our prevention of NCDs. Now, Prof, I want us to even start with the chicken or egg question, okay? As a nation, should we be spending more money on prevention or treatment of NCDs?
All right, thank you very much. It's good you said it's a chicken and egg question. I don't think that we have choices to make on this as to whether we do on prevention or we do on treatment. We have to do both, because both are citizens of Ghana. So, and again, we don't have unlimited resources. So I think that it comes back again to how we optimize the use of the existing resources. Those who have the conditions, we need to make sure that we treat it. What then it means is that whichever way, because the level of attention hasn't been as it ought to be, which means that we probably need new levels of funding or new sources of funding to be able to deal with this. And I think that earlier on, Labram talked about the issue of sin taxes and how we can exploit syntaxes to be able to deal with this. But again, I also think that I would emphasize, we need to make a business case. Because I think that every now and then, politicians find what is supposed to be their baby project and they allocate funds to it. If this is our next pandemic, maybe we are not making the case to the decision makers as we ought to make. And so we may need to think through this and make a much more stronger case for NCDs and be able to let policymakers understand how much do we save our economy if we make those sorts of investments across board. But what I would say is that we need to be very smart about the sort of interventions that we're putting in, both at the preventive and then at the curative level, because we are not going to have unlimited resources. And so that's the way I would look at it. We need to tackle both. But I would also say that we need to also pay a lot more attention to prevention, in the sense that the population at that side is much bigger. That population also has access to information. And for me, I think there are opportunities in there. The grown-up cohort don't have information. It's difficult to reach them. But the younger ones, they have access to information. We can reach them easily. So for me, it is even cheaper to deal with them at a much bigger space and to be able to get them there and stem that tide. So what it means is that over a certain spectrum, we will be able to reduce it and make savings, even to be able to take better care of those who are at the higher end of the age cohorts.
Now, Doc, let's get an idea of the typical treatment regime for an NCD. And there are so many of these NCDs. We've probably talked a lot about hypertension, which is the most common one, diabetes, but then there's cancer.
Yeah.
There's kidney failure and several other conditions that we are forced to manage under NCDs. Let's talk about the cost. In order for the hospital to treat such a condition, whether it's through dialysis or chemotherapy or whatever it is, exactly how, give us an idea of the resource cost that ends up being put on the, on the patient. But, give us an idea of how much it costs the hospital to treat such a patient.
Okay, so I can't give exact figures as to how much it costs, but definitely a lot of finances, a lot of financial resource goes into treatment. Because when you think about the fact that patients need to get medication, and then also they need to have dialysis like you mentioned, or they need to have chemotherapy, or if patients need radiotherapy, a lot of money goes into that. It's unfortunate that I can't give you an exact figure, but definitely a chunk of resources goes into getting that.
Do we have enough of those resources in our hospitals?
Well, we don't have a lot of resources. We don't have enough because for, if you say, as it cuts across, how many institutions, how many hospitals have dialysis units, okay? Very few in the country. They mostly have to rely on some private facilities who have it to be able to use it. And these days, we've been talking a lot about dialysis on the media. We have an idea about how much it costs per dialysis. Okay, so that's very expensive. So, and then also medication is quite expensive to have to buy medication because in recent times, the cost has gone up. And the problem is that when you come to the government facility and you don't get all your medication, then you have to go to a private pharmacy to go and get your medication. And in Ghana, there's no limit on the, what do you call it? there's no limit as to how much you can place as profit on medication. So you can go to pharmacy A, where the medication costs about 200 cedis, and the same medication will cost about 350 in another place. So then for one person to be able to get just medication for, if the person has maybe hypertension, diabetes, and high cholesterol, you're talking about more than 1,000 cedis to buy medication for just a month, okay? And then also, it's not for the treatment. Now we are not looking at just giving medication. We are talking about people changing their lifestyle as well and using food as medicine, okay? So when it comes to that, you're thinking about the person having to go and buy food. And the food, we've mentioned already that now it's more expensive. So if you add that as well, okay, exercise may not be expensive, okay? And then when you're talking about other modalities of treating, so when it comes to treating, it's not just about these things that we mentioned, food, diet, we're talking about sleep, we're talking about diet management and all that. So all these things contribute. And there are certain people that, I mean, they need to have what we call social connectedness or relationships. Somebody is just alone. You're talking about somebody, if they don't have that, then you have depression coming in and things like that. So all these contribute to the cost and then contributes to the NCD burden. So it's a big thing that we are dealing with that should not be, you know, just glossed over and then we just say that, oh, I mean, NCDs. I think something that can also be done, as we were discussing, is daily we were getting updates of how many COVID cases were coming up. So if you are getting prompts on WhatsApp and saying that the numbers are increasing, today is the 11th of July, but the number was 3,000, by tomorrow is 3,200, how many new cases are coming up? How many people are dying from it? And then people are looking at the figures and saying that this is alarming. I think that will, you know, bring up a wake-up call for us to realize that this is something that we really need to deal with.
That is such a good idea. In fact, while we're here, if you don't mind, I'd like to make a pledge on behalf of Multimedia that if the government can commit to gathering that data, we will commit to sharing it on a daily basis, if it has to be on the corner of our screens every day, if we have to announce it at the beginning of bulletins, we will make a commitment to disseminating that information if you make a commitment to gathering it, gathering the data.
Yes.
Okay, can we have a gentleman's agreement on that?
Let me say that, I mean, when it comes to the data bit, yes, for the routine data, we are now, I won't say we are certain, but we have started doing that through the integrated disease surveillance and response system, where we have hypertension, diabetes data being captured for a routine analysis. That is what we use during the COVID. Yeah, so you need a system to be set up to be able to produce those information for analysis. Apart from that, when it comes to the cancers, we have the cancer registry in Komfanoche. We also have one in Kolebu. These are not national level. So what is lacking is a national level integration, which we are working towards that. So we are now setting up the system for collecting that information for cancers and then for the other NCDs like hypertension and diabetes. So those are the things that we are doing for the routine data collection and analysis. There's also a WHO stepwise approach. It's a survey, standardized survey method for collecting information on risk of NCDs. Ghana has done it for the first time. We are doing the analysis and very soon the report will be shared. So for the primary data side or survey data, Ghana SASCA service is also supporting. The DHS also includes some information on NCDs that we can also rely on. But we want to get to what Doc said, that daily we can have access to the information and share with the public. And then I think that will help. So we have started that.
Yes. Prof, you had an intervention.
Yes, so I was actually going to give some bit of information to buttress what Dr. Thompson said. But again, before I said that, this issue of the gentleman agreement between the two of you. Personally, I think that this should not be difficult because during the COVID, what helped us to do that? It was the SORMAS.
Yes.
And I did some work on private sector collaboration, okay, for deploying Ghana's COVID-19 strategy. And one of the recommendations was how that work was funded by WHO. And one of the recommendations was, how do we learn from the data governance within that particular process? And here, one of the things I saw in that study was leadership at the level of the Ministry of Health. And that galvanized everybody, because now, even when we talk about data on NCDs, the data he will give you will be data from government hospitals. But a lot of work is going on in private hospitals. A lot of the rich people don't come to public facilities for their NCD issues. They go to private sector. And that data is sitting there. And if you put the private sector together, if you take CHAG out, I mean, they are something around 20-something, 30%. And that is huge. And that data is not available. But I think we can rely on the sort of infrastructure we put in place, the leadership that was shown by Ministry of Health and Ghana Health Service during COVID. We can activate the same process and deploy it for NCD. And we should be able to get this sort of data where we let everybody see what is going on. But back to what Dr. Thompson was saying. So in terms of resources, I'll look at it from two directions. I'll look at the direct dollars going into treatment. And I'll pick a typical case, say hypertension. Okay. The estimate for Ghana hovers around, if you take hypertension without complication, about, I talked about a base of about $486. And then those with stroke, they will spend maybe a bit of about 5.5. Those with myocardiac, about additional 39. But those with, say, kidney failure will spend additional $302 every month. So that is just the physical dollars. Then let's talk about the non-monetary resources that are deployed. Could you talk about, let's say, somebody with kidney issue? How many urologists do we have in the country? That's another issue. Okay, and yet everybody above 40 is a potential candidate. Yeah. Okay, but how many of them do we have? How many neurosurgeons do we have? Because if you have hypertension that leads to stroke and those things, where are they? So the point, and again, we are also unfortunate in the sense that the Western world is poaching almost all these people that we train, and only a few of them are here. I mean, if you look at the data in terms of the movement of the doctors and nurses, but I know she is not going. She would continue.
Amen.
She would continue to be here. So I think that all these things are drivers to tell us that we need to put our step forward as quickly as possible.
All right. Well, we're still on the Joy National Dialogue on NCDs. This national dialogue is brought to you under the auspices of Farm Access and NORAD. And there's still a lot more for us to talk about. Stay where you are. When we come back, we'll be hearing from you with your questions and opinions as we seek a way forward to stop the tide of death caused by NCDs. Stay with us. You're welcome back to this Joy News National Dialogue on Non-Communicable Diseases. This dialogue is being held under the auspices of Farm Access and NORAD. But we also have to give some special thanks to the Ministry of Health, Ghana, the Greater Accra Regional Hospital, Department of Economics at the University of Ghana, the School of Public Health at the University of Ghana Business School, as well as Focus Orthopedic Hospital, the Norwegian Institute of Public Health, and to the many patients living with NCDs, without whom we wouldn't even know what it's like. Our guests helping us with this conversation tonight, Dr. Jacqueline Thompson is a family physician at the Greater Accra Regional Hospital. Dr. Kwesi Boahene was with us earlier. He's the Director of Health Services at Farm Access. Professor Gordon Abekan Nkrumah is at the Department of Health Services Management at the University of Ghana Business School. Dr. Eric Nsia Boateng is Head of Monitoring and Evaluation at the Ministry of Health. Labram Musa is National Coordinator for the Ghana NCD Alliance. Now, we've got some messages coming through. Let me read a couple of them before we open up the phone lines. This one says, a suggestion for panelists. Please, can you tell your panelists that they should, through the Ministry of Health, write a letter informing corporate bodies to desist from calling any walkabout in town during their anniversaries a health walk. They could use terms like walk in town, walking hour, etc. Perhaps because the middle class does not walk much in Ghana. They want to deceive themselves that they have done a lot with a once-in-a-blue moon walk. I'm sure such walks have virtually no health impact. They perhaps only have a jamboree effect. This is a suggestion from Zach Yanem, who is in Zunarungu under Nangode in the Upper East region. Thank you for that message. Here's another. Good evening, Joy. A very important discussion. For me, I eat fruit every morning before cooked food, and sometimes twice with cooked food only once. And it's helping me a lot. So far, so good. So for so many years, I haven't visited the hospital. This is Ajman Joseph writing from Community 9 in Tema. He says he's AKA Ajingo the man. But he says the quality of the fruit and vegetables is the challenge. Ajman Joseph, I think there are many who will be able to relate. All right, listen, it's time to call us. The number is right there at the bottom of our screen. For those on radio, let me say it, it's 0302-216-91. I think we're missing a number there, okay? 0302-216-91. Don't know what that last number is. I will get it for you so that you can start calling us. But we certainly want to hear from you so it's 030-221-1691. Okay, so I was missing one of the ones. So 030-221-1691. Our first caller is Fred from Adenta. Hi, Fred. Good evening. I think we may have lost Fred from Adenta, but you can call us 030-221-1691. Okay, 030-221-1691. It's the Joy News National Dialogue on Non-Communicable Diseases, the silent epidemic. And we certainly want to hear your questions, your thoughts, your contributions, as we try to figure out how, as a nation, we can stem the tide of death. Francis calls us from Japan. Hi, Francis.
Hello.
Hello, good evening. Thank you for calling us.
Hello, good evening.
Ghana is listening. Please go ahead.
Good evening.
Good evening.
What a beautiful program. Yeah, but what as the panels, the members of the panel, those who are coming out now with ideas that they have come out with medicine to take away blood pressure, just one dose. Cure blood pressure. Is this credible?
Medicine to take away.
You're asking if it's possible for there to be a medication to cure hypertension. That's your question, right? Okay. Thank you, Francis from Japan. We will get you an answer to that. We'll take a few more calls and then we'll get our panelists to answer these questions. So you can call us 030-221-1691. Maybe I'll give this one to Dr. Thompson. Is there a medicine to cure hypertension?
Absolutely not. There's no medication that has been formulated that can cure hypertension. I think he mentioned that with just one dose. There's nothing like that. Absolutely not.
Yeah. That's the thing about these lifestyle diseases and non-communicable diseases, that most of the time there is no cure, only the potential of treatment, which is why we are so keen to prevent. But, you know, speaking of this, maybe we should address, while we're waiting for the next call, we should address the herbal medicine question. Now, I know how averse medical doctors are to the encouragement of herbal remedies, mainly because it's a very unexplored area. We don't yet have a grip on dosages and so forth. And in order for any medication to be prescribed as a treatment or cure for any condition, it has to go through some very rigorous medical trials, which cost millions, sometimes billions of dollars to do. These are all discouraging of herbal medicine. But we do know that there is evidence, there is case evidence of how effective some of these herbal remedies can be. As a nation, and I'll actually, I won't ask this question of you, Doc. I'll ask it of our government representative, Dr. Nsia Boateng. Should we perhaps get to the point where we invest in clinical trials for some of these more promising herbal remedies that have been, reported to have some positive results in treating non-communicable diseases?
Yes. I mean, in fact, at the ministry, we have even set up a directorate called we refer to as TAMD, that is Traditional Alternative Medicine Directorate. And there's a policy of integrating traditional medicines into the healthcare system. I think the last assessment that we did, we've managed to scale it up to around 54 facilities or thereabout. But
forgive me, we'll get more detail on that. I don't want James from the Central Region to stay on the line too long. Credit is expensive these days. Good evening, James. Do we have James from the Central Region?
Good evening, Master.
Good evening.
Like you said, I'm speaking from Central Region. Good evening, Master.
James, we're listening. Please go ahead.
I just want to find out whether there is really cure for diabetic, because my wife is a diabetic. I just want to find out whether there is really cure.
Okay. You want to know if there's a cure for diabetes. Okay, so this would be in the same vein as the first question about a cure for hypertension. So maybe we'll have Doc handle that the same way.
Okay, so these are, I think there are two different questions that have been asked here. The first question that was asked about hypertension is that if there is medication that can cure hypertension with just one dose, and my answer was no. This question talks about the fact that is diabetes curable? Yes, I would say diabetes is curable, but it's not for every case. Okay, so right now there's something that we call lifestyle medicine. So it's all got to do with addressing these non-communicable diseases that come about because of our lifestyle. So lifestyle medicine has got to do with treating the root cause of the disease, unlike conventional medicine that we are practicing, that has got to do with treating the symptoms and the complications. So it depends on the kind of patients that we have It depends on how long you've had the diabetes for and other things. So now, I think that as time goes on, we need to know that it is not every case of diabetes that can be reversed or put into remission.
I'll get you to expand on that answer because I'm very curious about that. But I don't want to miss Emmanuel Donko, who's calling us from Tamale. Hi, Emmanuel. Good evening.
Hello. Good evening.
Thank you for calling.
Hello. Good evening.
Yes, go ahead, Emmanuel. We're listening.
Yes. This is something that is so dear to me, and my PhD topic is on this. Apparently, I have tried to look at how to deal with NCDs from a fiscal policy perspective. Mr. Abraham is was one of my key informants in my study. When I reviewed the laws, for instance, on alcohol, you will realize that from 1962 up to date, there is no law in Ghana on alcohol that tries to deal with the menace alcohol is creating. You look at all the laws, it's all about the economic benefits. Talk about sugar-sweetened beverages. We don't have any law that talks about a prescribed grams in alcohol, in drinks or food, allowable grams as we have elsewhere. My study was on taxes, purely using fiscal policy to deal with NCDs. So even the recent tax that we have on what's it called, drinks, sugar-sweetened beverages, it's not, you realize that it doesn't address the issue. It does not address the issue at all. So what are we looking at? Are we seriously working at addressing the public health concerns, or we are much interested in the economic benefits of
all right.
coming up with?
I'll get Dr. Nsia Boateng to address that question, but let's see if we can take oh, that was our last caller. So, Dr. Nsia Boateng, this is someone who insists that we've never had any laws against some of these dangerous substances, alcohol, for example, or sugar, as we've talked about today, and he feels that that means we're not really addressing the issue.
You know, I mentioned in the beginning that if you look at the first national NCD policy, which was in strategy, the year 2014, what that policy helped us to do was to come up with a lot of regulations or legal frameworks to control it. So we talk about the tobacco control regulation of 2016-2017. And then the national alcohol policy, he is talking about a regulation, perhaps from maybe Parliament to control that. At this point, I cannot mention anything of that sort.
Right.
I want to believe that there could be some policies within institutions to address that. It may not come from Parliament to do that, but within the health sector, the agencies of the ministry, which now we have about 30, and the partners that we work with may have some guidelines to address that.
But you can't point to any legislation.
Exactly, just on that.
Okay.
And some of these policies that we have may also address some of, touch the issue that he's talking about. But because the fact that it hasn't gone to Parliament, like what the tobacco control regulation did, we may not have that at this point. But definitely it's something that we are working on.
Now, we're almost out of time, but I really want to give Dr. Thompson just 2 minutes to complete your explanation about this diabetes is curable thing. And the reason why I'm doing this is because the last thing I want is tomorrow morning for some people to start selling concoctions on the buses saying that they heard, you can hear it on Joy News that diabetes is curable.
Yeah.
Which types of diabetes are curable?
Okay, so I would like to say, but because right now, as I mentioned earlier on, that lifestyle is a part of treatment of these NCDs. Okay, so I'm not saying that there's a herbal concoction or there's any medication out there that people are selling on the streets that you can go and buy, and then you say that it will cure your diabetes. That is false. Okay, so certain measures that are put in place, that is what we call intensive therapeutic lifestyle change, that can be used to treat diabetes depending on the stage where it is. Okay, so if you have been initially for the first few months, and it is not for everybody, I must say that's like a caveat that I should put across, that it is not for every situation. So it's supposed to be dealt with on a case-by-case basis. So what I'm talking about is type 2 diabetes. There's a lot of evidence to show that certain people with type 2 diabetes have been able to have reversal or remission using ITLC, that is intensive therapeutic lifestyle change. Okay, so I'm not saying that everybody with diabetes can be cured. I'm not saying that type 1 diabetes can be cured. I'm not saying that if you have gestational diabetes, it means that go and drink a concoction or put A and B together. If your diabetes, we have to be able to screen you, we have to be able to take you through some rigorous, tests and other things, and subject you to certain treatments over a period of time before we will be able to say that you either have remission or reversal.
Thank you for that clarification. And I want to thank the entire panel for spending 3 hours with us tonight, starting the conversation that hopefully will lead to us stemming the tide of death that is upon us thanks to non-communicable diseases. You have been listening to Dr. Jacqueline Thompson. She's a family physician at the Greater Accra Regional Hospital. You've also heard from Professor Gordon Abeka Nkrumah from the Department of Health Services Management at the University of Ghana Business School. Dr. Eric Nsia Boateng has represented government in our conversation in his capacity as Head of Monitoring and Evaluation at the Ministry of Health. Labram Musa is the National Coordinator of the Ghana NCD Alliance. He's given us a lot of real-life perspective in our conversation tonight. And of course, we heard earlier from Dr. Kwesi Boahene. He's the Director of Health Systems at Farm Access. My name is Kojo Yankson. It has been a pleasure to moderate tonight's conversation, but this is only the beginning. You have to ask yourselves, what are you doing to preserve your own life? Every day, ask yourself that as we all seek to improve our health and avoid non-communicable diseases to stave off the next pandemic. Thank you so much for being with us. Have a wonderful night.